My name is Sheraz Daya. I'm from the Centre for Sight in the United Kingdom. We have 3 sites, 3 locations where we see patients in consultation and 2 where we actually do surgery as well. The OPD scan is fantastic. I've used it for 5 years. It provides a huge amount of information, but it needs to be presented in a comprehensive manner so it's understandable, and in a manner that I can use for both laser eye surgery and also lens surgery. So we came up with working with NIDEC. We've devised a report. It's called the Refractive Lens Exchange Cataract Report, but as I say, it's very useful for laser eye surgery too. Where I find the OPD scan very useful, and I have to say my staff will do an OPD scan on every single refractive patient at every visit. And I find it very useful for things like toric lenses, or where to locate a limb relaxing incision. I don't use the topographic data. I use the aberrations derived from topography. So if a patient has 0.75 diopters or more of astigmatism, I need to do something. Either limb relaxing incision, probably up to about 1.5 diopters, and beyond that, a toric lens. So the toric lens will align itself up in the direction as outlined on the aberrometry, and the LRI as well. It's very useful. You know, there are some patients who have non-orthogonal astigmatism, where the bow tie is at an angle. Well, how do you decide what the angle should be and where the orientation should be of the lens implant? Well, it's very simple using aberrometry, because it tells you what the overall axis is and also the magnitude of astigmatism. So all this information has to correlate with what you're planning to do. So a lot of people will say, you must not use, it's very dogmatic, you must not use multifocals in post-LASIK eyes. Well, actually, we've been doing it. And I started doing this very cautiously, looking at corneal maps, looking at the OPD scan to make sure there are no crazy aberrations in place. The one I'm most worried about is coma, because that is a really visually destructive aberration. But then so is spherical aberration. And I started very cautiously, and over time I realized, and also patients insisted on getting multifocal lenses, patients actually did well. We put the lenses in and they saw well. And I was looking at this data and I thought, what's going on here? And then I realized when patients have refractive lens exchange surgery, their pupils are small. So when you're looking at 6mm aberrations, that's pointless. And it shouldn't distract you from doing surgery on the patient. Look at their 4mm aberrations. If they're within normal limits, then actually that patient will probably do quite well with the multifocal lens. So the OPD scan is very useful for understanding the optics, what's going on preoperatively, what's going on postoperatively. It's also excellent for if anybody is interested in research and auditing their data. You've got all this information that you can put together, and you can acquire it very quickly. So we use the OPD scan a lot in a lot of our research and audit that we do at our centers. We're living in very exciting times. There are so many options now available for our patients, and we just have to understand what we're doing, and getting good diagnostics is really, really important. And I have to say that using the OPD 3 has revolutionized what we do in our practice. It's helped us in terms of patient flow, and our patient care pathway is constant. And that's fantastic. So we can plan patients' visits, we know exactly how long they're going to be in our clinic for, and so on. And the OPD 3 scanner is very quick to use. Our technicians love using it. So it's fantastic, and I would prompt colleagues to, you have to buy the device, try it out for yourself, get it on a trial, take a look at it in your clinic, look at those reports, and then you judge for yourself as to whether you feel it's useful or not. But I have to say I derive considerable amount of information from it, and I can't do without it.